Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Novartis, Allergan, Janssen, Biogen, AGTC, MeiraGTx, and the SickKids Foundation. We'd also like to thank Accessible Media Inc., our national accessibility partner. Everyone should download the AMI app, which is a fabulous resource, and you can watch excellent programming, including previous Fighting Blindness Canada events. Thank you for watching. We hope you enjoyed this webinar and share your thoughts with us in the comment section below.
Thank you, Morgan, and thank you, Larissa. I want to also thank the Foundation for inviting me to share information during this very critical time. All of us are staying home and following all the guidance that we're getting from the government and the public health bodies. So I thought I'd take a few minutes, maybe about 30 minutes today, to sort of review what we're dealing with in eye care and also what we're dealing with the coronavirus. So today's agenda is as follows. We're going to take a step through the science of SARS-CoV-19. We'll talk about safety and clinic preparedness guidelines, which medical clinics are now adopting to create a safe environment for patients. Following that, we'll talk a little bit about the ocular manifestations of SARS-CoV-19, and then take a step into sort of how are we managing patients in this particular environment where we are staying at home, working remotely, and being very particular about which patients we invite into the clinic in order to see them directly. And then, of course, I know everybody's here and excited about emerging technologies and therapies in retinal disease, particularly in age-related macular degeneration. So we're definitely going to spend a good amount of time going over some of the newest toys and technologies and even therapies which are exciting and are coming up the pipe. So I'll run this video and hopefully the audio plays, but if not, really what I want to highlight here is that the coronavirus has symptoms such as sore throat, headaches, fever, dry cough, shortness of breath. And inhalation of the virus tends to affect the exchange of oxygen, which you can see here. And as a result, when you don't get enough oxygen, you can't breathe, you have shortness of breath. And of course, whenever a virus affects our lungs or any part of our body, the virus goes into the cells, it replicates itself, but it also induces an inflammatory reaction, much like when you bump your elbow swells up. So similarly with the lungs, these small areas which exchange oxygen, they swell up, resulting in pneumonia and difficulty breathing. And this is really more serious for people with existing diseases, particularly senior population. And really what we want to do is do our best with hand washing, sanitary precautions. And we know this is really spread all over the world, so it's not to be considered trivial at all. And that's a brief overview of what we're looking at with the coronavirus, from an animated perspective. So as we've taken a leap forward, we've been adopting the way we practice medicine, knowing the degree of infectiousness of this particular contagion. So here's a photo of me on the left, and this is how I basically have to prepare myself for clinic on a regular basis. I have to wear goggles because the virus is able to be shed in people's tears. As a result, if someone's coughing, it can enter a mucous membrane like your eyes, and that's another port of entry. I'm wearing an N95 mask here. I know we've all heard a lot about that on the news, and this is a mask that reduces the transmission by about 95% of particulate matter. I'm wearing an impenetrable gown to prevent contact with patients and transfer a virus. And while not pictured, of course, we are wearing gloves, which we change between patient visits. What about in the clinic? So we've had to take it up a lot in order to make things a lot safer for our patients. On the left, you'll see one of our staff members who's dressed as I was, and we do the Ontario COVID-19 screening questionnaire right outside the door of the clinic. And this allows us to really screen out patients which potentially should be tested by the government or are considered high risk, in which case we triage the patient accordingly. All patients' temperature is taken outside the office with an infrared thermometer. Obviously, if someone had a fever, they would not be admitted to the clinic, and we would follow the Ontario COVID-19 guidelines. Every patient is given an ear loop mask so that they can feel comfortable breathing and exchanging communication with the office when they enter. Everyone's hands and mobile phone is sanitized prior to entering with alcohol wipes. And in the waiting room, we've now been recommended to limit patients' waiting room to patients only. That is, no family members or relatives, unless absolutely necessary. And when we look at the number of patients in the waiting room now, we're also limiting it to a specific number of patients. We'll go back here as I've skipped ahead. But what we're trying to do is to limit the number of patients so that we can respect the social distancing recommendations. And it's all really worked out well for the patients. The trajectory for patients in and out of the office is usually under 30 minutes, which is great from the infectious transmission standpoint. As far as the waiting room itself, we have implemented HEPA filtration. And what that really is that it's a very medically graded filtration system for the air to prevent viruses and bacteria from circulating in the air. All of the exam rooms and rooms where patients get diagnostic imaging have a ultraviolet C air filtration device. We are bleaching and sterilizing the doors, handles, and knobs, countertops between patient encounters. And then the actual equipment where patients receive their diagnostic testing, when indicated, is also cleaned with a UVC light sterilization. So you can imagine, I mean, to go from not doing any of these things on a regular basis, other than, of course, keeping your usual work environment clean and refreshed, to go to this level of protection requires the development of standard operating procedures and really thinking of every part of the patient's journey. So across the medical community, all of us have taken up this responsibility in a very serious way, and our dedication to patient care and providing a safe transit in and out of the office has become priority one. So let's talk a little bit about what are the ocular findings that we can see with people with this condition. Interestingly, the most common finding really is a red eye. Now, not all people that have COVID-19 have a red eye. In fact, it's a very small fraction. However, it can be one of the symptoms and signs of this condition. And there's a little bit of debate in the community as to whether this red eye is considered infectious or just an inflammatory reaction to fluid retention, which we know, as I saw from the video earlier, which is that inflammation causes fluid to be retained by the lungs, which makes it difficult to breathe. Similarly, inflammation and fluid retention in and around the eye can present with this red eye. So the eye is swollen, you'll see some tears, it resembles a pink eye. And so if you find yourself having symptoms like this, it is not unreasonable to contact your eye care provider. What about managing emergencies? I mean, so we're moving into this space now where we can't bring in patients as readily as we would have liked. So we have to be very particular and have a protocol to follow whereby we only bring those patients which are the sickest or have urgent or emergent issues. So we've received guidance from national and international physician governing societies and credentialing bodies, such as the American Academy of Ophthalmology, the Canadian Ophthalmological Society, and of course the various retina specialist societies. And really what they recommend is mandating treatment and examination of patients with sight-threatening conditions only. So if you are a patient that gets regular injections for macular degeneration, if you're having a surgical emergency like a retinal detachment, or you're having a serious ocular infection, or immediate trauma to your eye, those would be reasons to be seen right away. However, dryness of the eye, having a non-visually threatening condition, such as irritated eyes, for example, or blurry vision from your glasses needing to be updated, none of those at the moment are considered sight-threatening. But again, as a patient, if you are having any visual or ocular symptoms, the responsibility is for you to contact your eye care provider and let them make the decision, okay? We're also using virtual visits now. So telemedicine is actually becoming much more common because we are being forced to really be critical of who we bring into the office. So I myself and other healthcare providers are making phone calls to our patients to assess their ocular status, to do our non-urgent follow-ups with the patients on the phone, and then of course triage those patients that potentially need to be seen. And really all of this is being done to reduce the risk of patients and healthcare providers from having visits that they may not need, or visits that increase their risk unnecessarily. So it's a new world for us to practice in. However, we really are taking the seriousness of this condition and the pandemic to the utmost importance. And the goal really here is to do no harm and provide great care. So as we move ahead, we're going to talk about, I guess, what everybody's really excited to hear about is what are the emerging technologies and therapies for age-related macular degeneration. I see some questions popping up on the Q&A, and we'll definitely address them one by one at the end of the lecture. So emerging technologies and therapies for age-related macular degeneration. I'm going to introduce two new terms here. One is regenerative medicine, and the other is precision medicine. And really, regenerative medicine refers to trying to regenerate tissue within the retina. And it encompasses therapies inclusive of stem cell therapy. Whereas precision medicine, the goal with precision medicine is really to tailor the therapy to patients specifically. That is, as we look at patients' imaging or retinal scans or their genetics, it's to try to tailor the therapy to their specific DNA or gene-related issue. So both work harmoniously, but there are two terms that are going to be more commonly heard by you. So let's talk about a device-related improvement in what we are potentially able to offer to our patients. The first here is home-based macular degeneration screening. Now, those of us that have taken exams at our doctor's offices for macular degeneration are probably familiar with the OCT technology, which is used to scan the retina. And if you are a person who's receiving injections, then you are very familiar with this. So this is basically a precision medicine movement, and it's a company called 4C, which is working on this actually, and they have some innovative products coming. And one of their devices, which you can see in the top right corner, is basically a home-based Amsler grid type retinal screening device. And this is something that patients perform their own home testing every day. And at the slightest change based on their responses, the physician's office is notified that a critical change in the Amsler testing has occurred and the patient should potentially be brought in. So we'll take it up a notch. And if you look at the central image, you'll see the nodal vision home OCT. So instead of getting OCTs in your doctor's office, there's the ability to have an OCT done at home, a very simplified version, which would be used to screen for changes such as new bleeding, loss of tissue, or new fluid leaking from a prior blood vessel. And this again triggers the physician's office that a patient may need to come in and be seen and treated sooner. So the beauty of these technologies really is that it's of course very precise, it's specific to the patient's needs, but it allows this all to be done from the comfort of a patient's home. Thereby limiting visits to the doctor's office, which again, in a pandemic type scenario can be quite advantageous. So by detecting disease early or detecting early recurrences, the hope is that we save vision. The present status in the US is that it has FDA approval, and this is now being rolled out in the US. However, the Health Canada status is such that the company has yet to submit the product for approval. So it's a preview of coming attractions, and data is evolving, and we'll really get a chance to see how effective it is in the US market. So we mentioned regenerative medicine, which is basically cellular therapies. And this is actually very approved for dry, non-exudative AMD. And specifically a subtype of dry macular degeneration where people lose a segment of tissue, which we call geographic atrophy. And so this particular therapy type involves retinal pigmented epithelial cells being transplanted in the office, in the operating room, and being used to help regenerate the damaged and degenerated tissue. So just to sort of break this down a little further, geographic atrophy is like having mini potholes in the retina, or if the retina were to resemble Swiss cheese, those empty spaces are missing tissue. By delivering the pigmented cells back to the eye, the hope and expectation is that we regenerate tissue to fill those gaps, to fill the Swiss cheese, to fill the potholes, so that vision can return and the patient can see again. So the status is that this is currently a phase 2 clinical trial, which is happening internationally. And the company that's leading this particular regenerative medicine initiative is called APELIS Pharmaceuticals. So exciting things that are happening in the world of dry macular degeneration. We'll take a look at another therapy here. This is made by a company called APELIS, similar to the previous one. However, it acts in a different mechanism. So in macular degeneration, we see inflammation, much like in many other conditions, including cancer. And inflammation is central to macular degeneration. And so what really happens is that through this overactive inflammatory reaction, we lose that tissue, resulting in potholes and Swiss cheese looking retina. APL2, which is the green dumbbells you're looking at on the screen there, is a molecule that's been generated to last for an extended period of time. And it is injected into the eye, much like you receive an injection now in the office, if you're receiving injections. And APL2 actually functions to block an inflammatory marker within the whole inflammatory process. So on the top right, you'll see little orange circles, which say C3, and that represents complement factor 3, which is an inflammatory marker. And in the bottom right corner, you'll see that when APL2, the dumbbell, binds to C3, it becomes inactive. And so the goal here is not necessarily regenerating tissue, but preventing degeneration. So in some way, if these types of technologies and therapies were able to work synergistically, then not only would we be able to potentially slow down the degeneration, but also regenerate tissue. So the net effect, obviously, with APL2 is to slow down the disease. And the status of this particular product, which is being investigated, is in a phase 3 clinical trial globally. So, we're moving things along pretty quickly, and it's exciting to have therapies for conditions like dry macular degeneration, which for years we really didn't have much. Of course, wet macular degeneration does have treatments. And those of you that are familiar with them are aware that there have been several advancements over the last 20 years with wet macular degeneration. The next generation of these treatments is called brolucizumab, or the trade name is Beovu, which you can see in the left corner there. And this is for wet macular degeneration. This is the 4th generation of the class of medications which we call anti-VEGF, or anti-vascular endothelial growth factor. And so these are administered in the office, just like your other anti-VEGF injections. And the advantage of this particular drug is purported to be potential better removal of fluid and extended intervals between the injections. So the idea being here is that if we can dry the retina better and bring patients in less frequently, it's a step ahead. So where we are with the status for this particular drug is that it is FDA approved, and it is actually Health Canada approved. And presently, the drug company is working with the private insurance companies to get it covered, which will then be followed by coverage, hopefully, by the various provinces. And that can sometimes lag somewhere around 18 months. So we're on the cusp of a lot of new treatments for both dry and wet macular degeneration. And I can say, it's a very exciting time. And one of the most exciting aspects that I think we presented today really is the technology that allows patients to be at home, be screened at home, and allow the physicians to get the data remotely so that we can really be precise in deciding whom to bring in for treatment or monitoring and when, based on those devices that I presented earlier with the home OCT and the home AMSLR testing. So we've taken ourselves, on a very short but very informative journey on the science of SARS, how clinics are being augmented and prepared, what types of findings one could expect in the rare instances of an ocular manifestation of SARS-CoV-19, how we as doctors are now trying to be careful with respect to which types of patients come to the office and triaging patients using virtual care. And then a number of the emerging technologies from both devices as well as medications for both dry and wet macular degeneration. So with that, I'll turn it back over to our moderators and happy to answer questions. Thank you.
Perfect. Thank you, Dr. Choudhry. So we have a number of questions that are already popping up here. So I'm just going to ask them and you can answer them. So the first question is from Anne, and she says, as a healthcare provider, is there anything that I can do to support clients whose eye doctors have canceled ARMD injections due to COVID?
So that's a great question. I think the individual patients which are actively getting injections should be asked questions about whether they are noticing that their vision is getting more blurry, wavy, distorted. I think we can encourage our patients to use the AMSLR grid at home if they have an existing retinal disease. And if any changes are seen on those AMSLR grids, then it should warrant a phone call to the eye care provider who delivers their injection treatment and potentially have that patient brought in. So we have some home tools. I mean, having a home AMSLR grid is pretty good. It's been pretty much the standard of care for home screening up until these newer devices, as I described, become available.
Great. So I'm going to ask another question from the Q&A window. Again, that can be found at the bottom of your screen. You can click it. Or if you have difficulty with that or it's not accessible to you, you can also raise your hand. And to do that, you just have to use a keyboard shortcut. So if you're using a PC, you can press Alt-Y. And if you're using a Mac, you can press Option Y. And we can take those questions in turn, and I'll call on you when it's your turn, and it'll allow your audio from your computer to ask the question. So the next question from the Q&A is from Joyce. And Joyce asks, do the cellular therapies involve donated cells?
Sorry, can you repeat the question?
Yes, it says, do the cellular therapies involve donated cells?
That's a great question. So presently, the cellular therapies do not involve donated cells. These are synthetic cells which have been generated, the RPE cells.
Okay, great. The next question is from Anne, and she says, if you have only the red eye symptom, does it mean you have COVID-19?
Absolutely not. So obviously there are many, many reasons to have a red eye. The purpose of bringing it up in this discussion is that as an eye care provider, we now know that a red eye or conjunctivitis can be, in rare instances, a symptom and sign of a COVID-19 infection. And as such, that patients need to be counseled that should they notice a sudden red eye, for example, that their eye care provider should be alerted. And it should be now on our mind that this could be a manifestation of coronavirus. However, there are many, many causes of red eye. And because the likelihood of it being from coronavirus is super low, it's not necessarily due to coronavirus.
Well, that is personally a relief. So let's try to take a question someone who has their hand up. So I'm going to allow Sarah. Sarah's there, and Sarah, you should be able to speak now. You have to unmute, which I think is a shortcut of Alt-A on Windows or Command-A on Mac. Let's see if that works. I don't know if she can do it. Okay, well, I'll look into that. Let me see if I can try to do another question off of the Q&A. So the next question was another Anne. We have many Annes today. How close to clinical use are the drugs in phase 2 and phase 3 trials? What is the path forward?
So the path forward generally for clinical trials is that they do go through a variety of phases. And so the first sets of phases often focus on the safety of the drug. So is it safe in animals? Is it safe compared to the present standard of care? Should there be a standard of care? And then is it as good or as efficacious as the current standard of care? And then the question is it become superior to the standard of care? So when we talk about drugs that are in the phase 2 and phase 3, the phase 3 drugs are the ones that are closer to us being able to make them available for availability for use. But they do need to go through those exact stages, phase 1, 2, 3, and then phase 4 in order to fully become available. I can speak to the fact that, governmental bodies like Health Canada and the FDA, they want to ensure that, number one, patients are kept safe. We don't want to be instituting therapies that increase risks to patients unnecessarily. And when we have new therapies, we want to make sure that those therapies are at least as good, and in many cases better than what the existing therapies are. Now, when we think about geographic atrophy or dry macular degeneration, there's presently no treatment. So as such, drugs that meet the threshold for being safe and effective will likely get to patients' and doctors' hands faster.
Okay, the next question is from Linda. And Linda says, in the use of the next generation of anti-VEGF agents, Are clients still cycled between 4 weeks and 6 weeks to their visits to their ophthalmologists?
So the degree to which patients will be treated, meaning whether it's 4 weeks, 6 weeks, or more, really depends upon the type of disease that you have. So macular degeneration, while we have a good handle on many aspects of it, the treatment paradigm for each patient is still largely customized. So some patients need to come in every month. Some people can go as far as 2 months, and with some of the current medications go as far as 3 months. And these newer generation medicines possibly will allow us to extend that. So the answer is, it's really dependent upon your individual presentation of your disease. It's not cookbook.
Okay. The next question is from Linda, and she said, the self-screening devices that you spoke of, are they cost effective for a patient in their home?
So that's a good question, because cost is definitely a factor in any healthcare system. And so the cost effectiveness actually is presently being studied, particularly for the OCT, and it has been studied for the home screening, and it was found to be effective. So I think what we're going to see is obviously a much more cost-effective version, for example, of the OCT or other diagnostic devices like this, in order to make it available across the board, right? I mean, for example, if we had to have a home MRI machine, it wouldn't make any sense. So I think these devices are starting to be what's called disruptive, in that they're allowing us to change the way we would practice medicine. They allow patients more flexibility. And again, they really speak to the precision medicine aspect of where we want to take healthcare.
And a related question to that, Anna asked if you know what the current cost to the patient is for these at-home, well, it says at-home Amsler grid or OCT, and do you see this as something that will be sold to patients or possibly lent to patients by an ophthalmologist office?
So for Canada, we don't have the business modeling available at this time, because I know for the home OCT, the product has not been submitted in Health Canada. But in the US, it is a subscription model, and I believe the practice is primarily the subscriber, and the device is then given to the patient. And it's my understanding that, again, everything is centrally controlled, managed, and paid for by the practice. Now, in the US, of course, the healthcare system is slightly different, and so there may be particular governmental codes or reimbursement for that I may not be privy to.
Okay. There's an anonymous question said, as a healthcare provider, when a retinal doctor discharges a patient because there is nothing more they can do medically, it is important to refer them back to is it important to refer them back to an optometrist for pressure checks and glaucoma prevention?
Should have an eye care provider, and that goes without saying. So I think when a patient is discharged from a subspecialist, they still need a primary eye care provider. No different than if your neurologist discharged you, your family doctor, who's the central authority of your health, still needs to be involved. So I would always advocate for a primary eye care provider, in this case, as you suggested, an optometrist, to be managing the general eye health of people and patients. We're really trying to work in a continuum. All of us, whether we're generalists or specialists or subspecialists, we're working with the same goal in mind, which is to prevent blindness, capture disease early, and provide a good quality of care, if not great quality of care, to all of our patients. And I think working in cooperation, in tandem, having good open communication is not only great for practicing medicine, but it's great for people that are receiving healthcare. And we're all healthcare users.
Great. So I have a question that was emailed in, and this question comes about the potential risk of chloroquine and hydroxychloroquine, which have both been considered for treatment for COVID-19. So there is evidence to suggest that these drugs will have a negative effect on the macula. Is there a risk for individuals with macular degeneration or an inherited retinal disease? And is there a way to monitor macular health if a person is prescribed one of these drugs?
So hydroxychloroquine and chloroquine are drugs that are used in medicine outside of the whole COVID-19 investigation. They are used as immunosuppressive drugs to suppress the immune system and suppress inflammation. And they are commonly used by rheumatologists, for example, for conditions like lupus, rheumatoid arthritis, and others. So as eye care providers and as retina specialists, we are all familiar with the fact that hydroxychloroquine and chloroquine do concentrate the drug within the retina, which has possible toxic effects. And if you're on a high dose or you're on a dose for a long period of time, toxicity is observed. And that toxicity manifests with decreased vision at night, and it can result in visual field loss and ultimate vision loss. And so it's not trivial when we discuss drugs like hydroxychloroquine and chloroquine. So from an eye care perspective, when patients come to see me before they start this drug for their rheumatoid or lupus, or are being monitored for their ongoing treatment of lupus, rheumatoid, etc., and they're on these types of drugs, they do get specific testing, which can include a visual field, an OCT scan, which you saw earlier, and other imaging tests, which can be very sensitive at detecting early vision loss and toxicity-related complications. So yes, we're familiar with it. It's investigated right now for coronavirus. And there are serious complications that we need to be aware of, which we are aware of, as they pertain to people's vision and their retina.
Thank you. So Meg has a question. If a client has advanced geographic AMD, would they be a candidate for therapy, or would their loss of photoreceptors make them too far gone? And have any clinical trials for this started in Canada?
So the question about whether someone with advanced geographic atrophy is a candidate for a particular trial depends on the trial. So all clinical trials have criteria, and I can speak to the clinical trials that I was discussing earlier. They have size cutoffs for the degree of degeneration, and those areas of degeneration are measured from tests like we saw earlier. And based on the size of the degeneration, a patient may or may not meet candidacy for a clinical trial. And as far as clinical trials happening in Canada, yes, there are a few sites which have been selected for these trials. Our site here in Etobicoke is one of them, and there are others. And so yes, we're lucky that in Canada we will get access to these clinical trials. And I think the foundation has done a great job. Fighting Blindness Canada has really stood up and helped advocate for Canada and recruit clinical trials from drug companies, which would previously have potentially ignored this market and our patients.
That's great. And Meg also asks if the self-screening equipment that you spoke about earlier turns out to be too costly. Is there potential that this equipment could be placed in local drugstores for clients to do a self-check periodically, I guess similar to like the blood pressure cuffs at the pharmacies?
Yes, telemedicine, really is exploding. And this company that I mentioned earlier with the HomeOCT isn't the only company making this technology. There's two others that I'm familiar with. And usually whenever you have more than one vendor for a particular product, the price gets driven down. So that's actually a good thing for all of us users and providers. But as far as making telemedicine products available in pharmacy or in central locations, yes, we are already doing that in Canada through teleophthalmology programs, which are screening for diabetes, which are led by some of the bright doctors in Ontario and across Canada. And I think we're going to see more and more of that. And I'll tell you, we're probably going to be seeing some of that integrated with artificial intelligence. So it's exciting for providing this kind of care and also streamlining healthcare in general across an otherwise very large country.
Sorry about that. I had a little technical moment. So we have a couple more questions. Let's see. So Douglas is asking, I think, a really important question that a lot of people have on their minds right now. And he's asking if injections, specifically Lucentis injections, are still being done at this time, or are things sort of on pause because of COVID-19?
So injections are still being done, and I think it's generally provider dependent. Most of us are doing our best to be able to provide the injection treatments to our patients that need it. In some disease states, for example, in diabetes or retinal vein occlusion, if we can stretch out the visits to a lesser extent, then that is also advised. And I think one of the barriers initially, and hopefully is improving, was physicians and medical clinics' access to the protective equipment that I described earlier, all the garb that we have to now wear to provide care. So I think in some circumstances, clinics were restricted in access to that type of gear, and therefore may have had to slow down their treatments for patients. But I expect that that should be getting back online very shortly. But ideally, yes, we don't want to leave patients in the periphery and going blind or losing vision because of inability to access their treatment.
Okay, great. And I think we have one last question. This is actually a follow-up to your previous answer from Meg's question. And she said, if a client was interested in the therapies that you were just speaking about, what would be the process? Do they speak with their ophthalmologist, or what should they do?
Yeah, I think really the best way to go is to speak to your ophthalmologist, and always have a line of communication with your healthcare provider if you have questions or research that you've done or queries about a new therapy. I'm sure the doctors would always be happy to have that conversation and navigate their patients to the appropriate center that may or may be doing that type of research.
Great. Thank you so much, Dr. Choudhry.